Good evening. I'd like to welcome everyone to the COVID-19 Vaccine Facts Not Fear Vaccine Safety Webinar for Healthcare Providers for February 16th, 2021. My name is Donald Moore, and I'm with the Virginia Department of Health. I'll briefly cover a few administrative announcements before we begin. The discussion format is 45 minutes of moderator-asked questions of the expert panelists and 15 minutes of Q&A from attendees using the chat functionality. Attendees who join by telephone who have questions should send their questions to eprtraining@vdh.virginia.gov. For accessibility information regarding this webinar, please refer to the URLs provided in the chat. Your feedback is requested regarding the panel discussion webinars. Please complete the survey. The link is provided in chat. Your expert panel for the evening is as follows. Dr. Norm Oliver, Commissioner, Virginia Department of Health. Dr. Kosti Sifri, Professor of Medicine, Director of Hospital Epidemiology, UVA Health, Division of Infectious Diseases and International Health, Co-Chair, VDH Vaccine Advisory Workgroup, Safety and Efficacy Subgroup. Dr. Richard Wenzel, Emeritus Chair and Professor of Medicine, Division of Infectious Diseases, VCU, School of Medicine, Editor-at-Large, New England Journal of Medicine. Your moderator is Dr. Wakish Benson, WB Orthodontics, President, Peter B. Ramsey Dental Society. I'll now turn it over to Dr. Benson.
Good evening. As we kick off this informational panel, I think it's good for us to review where we are with the numbers. Dr. Oliver, to set the stage regarding the importance of this vaccine, please tell us a bit about the COVID-19 numbers in Virginia.
Thank you, Dr. Benson. Can you hear me okay?
Yes.
Okay, wonderful. So good evening to everyone who's joined us in this webinar. I hope it's informational for you. I think it's important to realize that the COVID-19 pandemic is still raging. The numbers back in January were pretty high. They're running about 4 or 5 times higher than they were when we were seeing the surge in the beginning in April and May of last year. And we can take some comfort in the fact that those numbers have been declining in the last week or so. However, with that decline, we're still seeing a lot of cases across the Commonwealth. Our incidence rate is about 32 cases per 100,000 of our population. That places us up in about the top 10 states in terms of the amount of cases that we're seeing, and that's still significantly higher than we were seeing back in April of last year. Our test positivity is 9.1%, which is an indication of how well we're testing. We're doing sufficient amount of testing, and that's good. Hospitalizations for COVID-19 have also been declining in many areas across the Commonwealth, and that's also good. So if those trends continue, we can, as I said, take hope in that. There is, however, an issue with the advent of the so-called UK variant and South African variants, both of which have been detected in the Commonwealth of Virginia. Those variants are significant because of their infectiousness and then how quickly they double as they infect others. So that we've seen about 13 cases or so of the UK variant, and that's just the ones that we know of. I suspect that if we know of 13, there's many, many more than that that are actually out there. So we're in a race right now to vaccinate as many people as possible before the UK variant, which is the one that our models show will become the most dominant one in the state probably in another couple of months. We're in a race to get people vaccinated before this new variant causes many more cases and could lead to another surge. So that's where things are with the pandemic right now, Dr. Benson, I'll hand it back to you.
Can you also discuss the allocation phases of the vaccine distribution and when you anticipate that we will move to the next phase?
Phase 1 is broken into 3 sub-phases. Phase 1A was what we began with, where we focused on the healthcare professionals wanting to ensure they're getting the vaccine and protection from COVID-19 so that they would be there for us, the rest of us in the Commonwealth, should we become ill, not only with COVID-19, but with all the other issues that are dealt with by our healthcare professionals. That we shifted then to phase 1B, which includes another section of frontline essential workers. We've been focusing on law enforcement, correctional facilities, staff and inmates, child care, K through 12 teachers, child care workers. And in each of these phases, in addition to dealing with frontline essential workers, we also have focused on a particularly vulnerable population. In phase 1A, that was residents and staff of long-term care facilities, skilled nursing facilities, assisted living facilities. In phase 1B, it is people 65 years or older, and all adults who have any chronic medical conditions that put them at higher risk for either very serious illness from COVID-19 or death. That's a very large population, somewhere around 4 million people. And we are getting about 130,000 doses of the vaccine each week. So our supply is scarce. And if we were to stay at that size for if let's imagine we never got more than that, we would be well into the fall before we could get all of those people vaccinated. We don't think that's going to be the case, as you'll hear throughout the rest of this webinar. There are other vaccines on the horizon, and we also expect production of the Pfizer and Moderna vaccines to increase. So given that, I would say it's reasonable to assume that in probably 3 months or so, we ought to be able to saturate the phase 1B population. And by that, I mean vaccinate everyone in that population who wants to be vaccinated.
Thank you so much, Dr. Oliver, for that valuable information. We will move on now to Dr. Sifry. People are concerned that this vaccine was approved so quickly, while other vaccinations have taken years for approval. Can you talk about the EUA process and how it differs from the standard approval process? And how can we be sure that the approved vaccines are safe?
Yeah, thank you very much, Dr. Benson. It's a pleasure to be here with you tonight. So I think this has raised some concerns that we often have with our patients when we're talking to them about vaccinations, about these particular vaccines. So what I like to emphasize is that there's not been a shortcut in terms of the clinical evaluation process, that rather there's been a removal of the intervening processes, the process that would slow development of a vaccine, and also some parallel processing so that things are occurring at the same time for efficiencies. So let me walk through that very quickly. So the first thing to understand is that the understanding of how to approve specifically these messenger RNA vaccines, and we could speak about the other types of vaccines in development, but focusing on the 2 that are currently authorized, that's built on several decades of clinical research. So there was an understanding of the opportunity and the ability to develop these types of vaccines very quickly. Since these are a platform that are amenable to genetic information, they are built on genes. Soon after the identification of the virus, when it first emerged in Wuhan, within 2 months, clinical trials, initially starting with the messenger RNA vaccines, were starting at the NIH. So the first thing to understand again is a vaccine effort that was built on decades of research. And then I think what occurred after that, I think that is very smart. That was what Operation Warp Shield was developed to help work with, was in essence to develop a set of efforts that did helped the vaccine companies with these public-private partnerships, the pharmaceutical companies, to have similar goals, similar outcomes that were measured, and to use a vaccine network, a vaccine clinical trial network. It's actually a set of four networks that are stitched together to test these vaccines at the same time with the same outcomes, with the same measures in terms of vaccine efficacy and safety. And also what will become really important in the future, an understanding of the secondary outcomes of vaccines, such as antibody response and T cell response, so that we're able to, in the future, understand if a vaccine's is efficacious as efficacious as the ones that are currently approved by comparing them with these other secondary measures. Importantly, what Operation Warp Shield also committed to was the purchase of these vaccines in large amounts, even though it wasn't clear at the time whether they'd be effective or not. Going into this vaccine development effort, it was not clear whether these vaccines would be 10% effective, not effective, 20%, 40%, or 95% effective, as they ended up being. So the committal to purchase these vaccines in a large amount, let these pharmaceutical companies invest in the processes to develop the vaccines before we know what the results of the clinical trials were. I think that is, in a nutshell, why these vaccines were able to go from the identification of this virus and identification of the target gene, in this case, the spike protein gene, the S gene, to an effective vaccine in a matter of 10 months. In terms of understanding what their safety is, it is really fundamentally important to understand that the same processes in terms of understanding dosing, vaccine safety, as well as efficacy, has undergone the same clinical trial rigor as any other clinical trial for a vaccine. The sizes of these vaccine clinical trials were as large as any other vaccine that's been brought to market recently. 30 to 44,000 people in these clinical trials, some of them with an international footprint. And the big difference, of course, with an authorization versus an approved medication is the time of follow-up. So what we do know is that most vaccine side effects occur very shortly after vaccination. That's what we've seen with these, and we can talk about vaccine side effects a little bit later. But importantly, other side effects, while they may be rare, can be measured for a period of time. And so what the authorization allows us to do is to accumulate that information about what the experiences with these vaccines in large populations, and once those data are collected, to then move forward with an approval process with the FDA. And that's what we'd anticipate will occur later this year.
Thank you, Dr. Ziffer, for that approval information. And we would like Dr. Wenzel to help us understand the two approved vaccines. How do the mRNA vaccine work, and how do they differ from older vaccine technology? What additives are in them?
Sure. So these are really new vaccines in terms of a major public health advance. In general, for example, if I look at influenza, we've had killed vaccines. So the whole virus is killed, injected, the body responds and makes antibodies that are protected. Similarly, with influenza, you can have a live attenuated vaccine, so still living, but harmless. And again, the body sees a live virus and makes antibodies to it. What's different here is that we now really are injecting the instructions, if you will, the RNA, the messenger RNA, that actually is the blueprint for what the cells should do. And so what the cells do when they see this messenger RNA is actually make the spike protein, because that's what it's been ordered to do or programmed to do. The protein is then dispensed in the body. The body sees this as a foreign material, makes antibody to it. The they're really amazing sort of new platform for us. As far as are they similar or not? I think you were getting at that. Yeah, they're very similar. I don't think I would call them interchangeable yet at this time. They may well be, but I would say to a person who got the Moderna vaccine first, get the Moderna booster. Again, Pfizer first, get the Pfizer booster. Let me see if you ask me anything else. What additives? Okay. So there were obviously what you have is the messenger RNA encased within 4 lipids, a nanoparticle. And the lipids are complicated, and some of them have polyethylene glycol. I just mentioned that because Sophie just mentioned that you can have some side effects, and some people are saying maybe the severe allergy in some people might be related to polyethylene glycol. And there are a number of salts as well as the messenger RNA. So these are a template that allows change later on. So in fact, if some of the new variants that you've heard about become widespread and appear to not respond to the vaccine in a favorable way, with this platform, messenger RNA, new vaccines can be developed within a fairly short period of time, under 6 months. Some are even, people are saying even more optimistic times.
Thank you, Dr. Wenzel, for the discussion on the vaccine mechanism. At this time, Dr. Sifry, what types of effects are likely to occur from the vaccine? Can they be managed post-vaccine with anti-inflammatories or antipyretics?
Yeah, so I bet most people that are on the call now have been vaccinated, so they may be able to speak with experience as to what type of vaccine side effects that most people would experience. And most of them are going to be local reactions, sort of pain and discomfort, within a day or two, maybe lasting up to 3 days at the site of injection. And then I think as well publicized, people can have reactogenic symptoms. So people can develop things like fevers, headaches, fatigue, symptoms like that. That's more common after the second vaccine, and it's also more common in people that are younger in age. It's anecdotal, but I think that there is a wide, variety, and we've now vaccinated, I think, 15,000 of our healthcare workers. And they can be from, I have essentially no, discomfort, no symptoms except for maybe a little pain and discomfort, to people sometimes missing, 1 or 2 days of work. So I think that's pretty well, set out. Those symptoms, particularly those people that have more reactogenic symptoms after vaccination, can be treated with antipyretics afterwards, and anti-inflammatories like NSAIDs. We generally encourage, and this is part of the CDC interim guidance, is not to pre-medicate people in anticipation of those side effects. There is at least some theoretical concern, and I think maybe some pediatric data with other types of vaccines that I think is a little bit, not particularly strong, but to suggest that if you were to pre-medicate, you may be blunting some of the immunologic response to the vaccine. So it is guidance, and I think it makes sense to say, let your body react to this, to the antigen that Dr. Wenzel just said was being made and to which you are developing immune response to. Let that happen, and if it is not tolerable, if it is causing too much discomfort, then to treat it symptomatically. So those are the most common side effects. There are less common side effects, like local adenopathy has been reported. There's been some reports out there to say, make sure to not start doing lymph node dissections concerned with breast cancer in people that have just been vaccinated with this vaccine. For example, there has been some concerns that have been raised about Bell's palsy that we're seeing in the clinical trials. Not a lot of cases, 4 cases, if I remember right, in the Pfizer vaccine, and 3 cases, or maybe 4 cases total in the Moderna vaccine, 3 in the vaccinated group, 1 in the placebo group. not clearly causal, because Bell's palsy does occur in the population, and it was the determination of the FDA that those rates seem to be at about the level that you'd expect in the baseline population. So those are the things that have been discussed most commonly, I think, around these vaccines.
Thank you so much. What is the risk of anaphylaxis or severe reactions that we hear so much about?
Yeah, that really came out very quickly, the concerns for anaphylaxis, I think within several days of the initial use of the Pfizer vaccine in the United Kingdom. And I think we probably most of us remember that there were 2 nurses that were reported to have anaphylactic reactions shortly after receiving them in England. And that's now been investigated systematically and reported in MMWR using the VAERS reporting system, taking a look at the initial vaccine use, both of the Pfizer and the Moderna mRNA vaccines. And what's been reported to date is that they are rare side effects, but they have occurred. So if I remember right, I think there were a total of 21 cases in the initial 1.9 million doses of Pfizer vaccine that were distributed. So on the order of 11 cases per million vaccinations given. And I think the number for the Moderna vaccine was on the order of 10 cases in the initial 4 million doses given, so 2.5. So I think that's sort of what we're talking about is, a rate of these severe allergic reactions or anaphylaxis on the order of 2.5 to 10 per million doses vaccinated. So it's a small number when you're talking about an individual vaccine. When you're talking about large populations of people being vaccinated, it becomes something that needs to be anticipated, understood. As Dr. Wenzel was alluding to, one of the concerns of maybe how these reactions are occurring, perhaps maybe in components of these lipid carriers, the nanoparticles, and in particularly pegylated interferon or polysorbates, which are in other types of vaccines. So PEG may be that allergen that stimulates this response. So people that have had a reaction to to anything with PEG would have this as a potential contraindication to this vaccine. But I can tell you from my experience, there is a caution that's noted for people who have had history of severe allergic reactions or anaphylaxis to injectable medications or to vaccines. And we deal with that in our vaccination center not uncommonly. And for the most part, we'll just watch those people who receive the vaccine longer than normal. 30 minutes is what's recommended, and that's what we do. And just keep a close eye on them after vaccine, and that suffices. We, in our experience, have not had any anaphylactic reactions to date, but I know that they have been reported at some other centers around the state. One thing I've also forgot to mention, though, that it's important to know that from the initial reports, at least from Pfizer and Moderna, is that most of these side effects were relatively easily treated. They did not require hospitalizations. There were some exceptions to that rule, and for the most part, they occurred fairly shortly after vaccine, sort of within that initial 15 to 30-minute window. So I think that those are important guidelines and things to understand when giving vaccine.
Thank you so much for explaining the vaccine adverse effects. Dr. Oliver, many in the dental community would like to be vaccinators. Can you discuss what that would entail to be a vaccinator?
So that actually winds up being 2 questions. One is being able to volunteer, for example, as a vaccinator at a vaccination site, these points of dispensing that we have set up across the Commonwealth. And the other is being able to provide that service to your patients in your own clinic, your own practice. So on the first one, I think that you all may be aware that there's a bill in the General Assembly that has been adopted. I'm also certain that the governor will sign it. House Bill, if I remember correctly, 2333, that would extend to dentists and other clinicians the ability to be vaccinators in a situation like a pandemic, and specifically with COVID-19. So the quick answer on that is yes, you could be a volunteer in one of our points of dispensing. Once this bill is signed, there's some for clinicians, we've waived a lot of the training that was required for other vaccinators. If you volunteer for our Medical Reserve Corps, which is now like up to like 27,000 people, Virginians have really responded quite nicely by stepping up and wanting to help others. So people there have to do a bunch of training on emergency preparedness and all kinds of other things that we've waived for clinicians. And in about just a few hours of training, you can become a vaccinator. Those of you like Dr. Sifri and perhaps Dr. Wenzel know that when you and Dr. Klein, when the Pfizer vaccine, for example, is so finicky. You know, most of us, if we picked up a vial of something that was cold like that, we'd shake it before you know, drawing it up into the syringe. And if you do that, you just wiped out 11 doses because you can't shake it. I mean, little things like that, little tricks you have to learn, but it doesn't take long to learn that. So yes, Dennis will be able to do that. As far as providing this service in your practice, that's more complicated. To do that, you have to sign up with the Virginia Immunization Information System, our registry, and have ability to then load information into that. You have to be able to load information into the tracking system, VTRAX, which is run by CDC. You have to apply to the CDC so that you can get access to that. So it becomes a very complicated sort of procedure. Susie Silverstein has dropped into the chat the information around what you have to do to get your site approved. And if you're dealing with the current vaccines, both require special handling. The Pfizer requires ultra cold storage, minus 80 degrees centigrade. The Moderna is a little more friendly, but still difficult. I think it's minus 20 centigrade that you need to store it at. So you need all kinds of, and the CDC requires not only that you have the ability to store it, but you have to have special measuring instruments to demonstrate to them that you are in fact storing it consistently at that temperature. So that becomes a big hurdle for any practice to put into place. But and then perhaps most importantly is just the extreme scarcity of the vaccine. We would love to be in a situation where this COVID-19 vaccine was in the hands of primary care providers, both of oral health and other physical health, had the vaccine available and able to treat their patients with and give them this vaccine. We just don't have enough to really distribute that across all the many physicians, dentists, and other clinicians who would love to provide this service for their patients and clients. Hopefully that situation will change in the not too distant future.
Thank you so much for allowing us to learn more about becoming a vaccinator. I see that it's easy to just join another site than to become a site.
Yes.
Dr. Wenzel, what do you know about vaccinating special population, those that are pregnant, planning to become pregnant, children, immunocompromised? Could you tell us a little bit about that?
Yeah, there are a few data, but both the Pfizer and the Moderna vaccine group that volunteered included some women who were pregnant at the end. They could small numbers, as well as some immune suppressed people. Both vaccines are different, with one cutoff at 18 and one cutoff at 16, but there are new studies that'll go out, and we can come back to that testing it all the way down to 12 or even lower in some populations. So basically, if I want to focus first on the pregnant women, point out first of all that COVID is a risk factor, or that pregnancy is a risk factor for COVID. Depending on which study you like, one from New York or one from Sweden, pregnancy and COVID increase the risk of getting into an ICU by 50% or fivefold compared to pregnant non-COVID. So it's truly a risk factor. And just the analogy that many use is with influenza, well-known risk factor for pregnant women as well. And we've never seen a study controlled of pregnant women getting a vaccine versus those not getting a vaccine. And what we have done is say, look, this is a vaccine. We really say everybody who's taking care of pregnant women, make sure they're vaccinated. So what's happened is with the OBGYN Society, what they've said is, look, this should be a discussion, first of all, with pregnant women and their OBGYN physician, and come up with a risk benefit, but really in a way encouraging them to go ahead if they are comfortable with that, getting the vaccine, knowing that COVID is such a risk factor for them. And so, full disclosure, I'm a vaccine advocate. I see no downside for vaccinating pregnant people, immune suppressed people, and pretty soon we'll know more about children, about their safety. But in the meantime, if you're immune suppressed, again, you sit down with your immunologist, talk about the vaccine, talk about the disease. And the question is, although, you know, there in theory may be some risk to those people who are immune suppressed, to me, the only risk is it may not work. And so you can check later on and get antibodies. So I don't see any major downside. But with the immunologist, come up with a discussion that says, what if I had got COVID? Well, if you're terribly immune suppressed and COVID, the outlook isn't very good. And so again, I really strongly favor going ahead. But the official across the country statement would be, have a conversation with your specialist and see what you think the downsides are of getting vaccinated, particularly versus those getting COVID.
Thank you, Dr. Wenzel. Your response was very insightful. We'll move on to Dr. Sifri. If someone has already had COVID-19, should they get vaccinated? If so, how long wait before getting vaccinated?
So another great question and a common question, unfortunately, because we do end up having a lot of people who have had COVID who are then coming up against this. So the first thing to know is that you should not get vaccinated if you're still having or recovering from COVID. Kind of self-evident, right? But you don't need to get a vaccine while you're sick. However, I think this gets into the question of vaccine efficacy and safety in this particular population. So an interesting piece of information to understand from the Pfizer study is that while COVID is uncommon in the first 90 days after primary infection, it does occasionally happen. It's pretty darn uncommon, but it did appear that that COVID vaccination was protective in those people who'd had infection in the previous 90 days. There weren't that many. That was an exclusion criteria, but not everybody got sifted out in the Pfizer study. So it does appear, based on some limited information, that vaccination may be helpful even in those who've had COVID vaccine in the past. But I think as or more importantly, one of the initial concerns was, would there be any potential problem with getting a COVID vaccine if you've had COVID infection in the past? Would there be sort of a hyperimmune response, for example, due to that? And that has not been seen. This vaccine has been safe in those people who've had COVID infection in the past. There's not been like enhanced side effects with that have been reported. So that is something that you can be rest assured about. And importantly, from a operational standpoint, you don't need to rule out COVID or a history of COVID in people who've been vaccinated. The question then it comes up to should you get vaccinated, and what the timing should it be if you've had COVID in the past. And so, the recommendations are generally per CDC is to get vaccinated when it's your turn to get vaccinated. In fact, there is information to suggest that an immune response to the vaccine may be better than natural infection. At least there's maybe some support for that based on some in vitro data. So I think that that's advisable. You don't need to rush, perhaps, to get it within the first 90 days after recovering from COVID. So there are allowances to say, if you've had an infection in the last 90 days and there's other people in front of you in the queue, it's okay to go ahead and to put yourself in towards the back. But I'm of the opinion, particularly for healthcare providers or for patients that are at risk, or really the groups that are currently being vaccinated, as Dr. Oliver was just going through in terms of who's being vaccinated now. If you've had a history of COVID within the last 90 days, you've recovered from it, to go ahead and get vaccinated now.
Thank you. What if they have received monoclonal antibody treatment? Should they still get vaccinated?
Yeah, now that is a contraindication to vaccination if you received the monoclonal within the previous 90 days. So those are specifically targeting epitopes and high titers for the spike protein that's being produced by the messenger RNA. So current recommendations are to not vaccinate within those 90 days after infusion.
Thank you so much. Dr. Oliver, if dental health professionals have difficulty accessing the vaccine, what would you advise them?
I would advise dental health professionals who are having difficulty getting vaccinated to contact their local health department. Dentists are in a high priority group. They're healthcare professionals, and we want them to be vaccinated. You really should be in the front of the line. So if for whatever reason that has not happened yet for you, contact your local health department. Someone can, in a moment, will drop in a link to our local health department finder on our webpage, so you can easily get that telephone number and website.
Thank you. How can the general public find out when and how to register for the vaccine? And what is planned for people who do not have the capacity to sign up online?
We are launching a website. It's up now, called vaccinate.virginia.gov. If you go to that website, there is a form there where you can we call it pre-registration. We don't have a scheduling software yet that we can use on this website. It's in development, and we expect in the next few weeks we'll have it up there. But you can put your name on this, essentially on this waiting list. It's the functionality of this tool that we have on our website allows us to also let you know that you are in fact on the list, which is one of the things that people are quite concerned about now. You register and then you don't hear anything for weeks and weeks and weeks and weeks. And do they even have my name? Well, now you can go to this site and search for yourself and verify the fact that you are there on the waiting list. When the scheduling tool is up, everyone who's on that waiting list will be then moved into the scheduling tool and scheduled in the order in which they registered, and new people who call in or come to that site can also schedule themselves. There will be a news conference tomorrow that the governor will be announcing the setting up of a call center. With this call center, we'll be able to take calls from people who have questions about COVID-19, about the vaccination campaign, about pre-registration. They'll be able, if they are unable to fill out the form themselves online, the agent will be able to do that for them when they call in. So keep your ears peeled. That doesn't really work, does it? Listen for that one tomorrow at the governor's news conference. So we'll be able to reach people who are both online and people who only have access to a phone to get this information.
That sounds good. I'll be looking for it tomorrow. Is there a cost or a copay for vaccines? And are there residency requirements to get this vaccine?
For people receiving the vaccine, there's absolutely no cost, and we never ask about. We don't in the health department don't even ask for any kind of proof of citizenship or anything like that. And I don't believe any of the healthcare systems are doing that either. Everyone who is a resident of the Commonwealth, everyone who's a resident of in the United States is being offered this vaccine, and they're being offered this vaccine at no cost. If you have commercial insurance, um, the commercial insurer is being billed for the administrative costs of providing the vaccine, because there are administrative costs for this, obviously. If you have Medicaid or Medicare, they are covering the administrative costs. And if you're uninsured, Health and Human Services has a what they call a provider relief fund that will pay the administrative costs. So everyone can get this vaccine without cost to themselves.
That's good to know. Dr. Wenzel, what do you know about whether the vaccine will work against the new variants that are being reported?
Great question and an exciting one. So there are a couple of studies out there, a natural experiment. Let me talk about Brazil first.
Okay.
Some of you know that Brazil had a huge outbreak of COVID, and it peaked last spring at about April, maybe a little bit later. And then with a huge proportion of their population infected naturally with all the terrible consequences, the rates went down. And then just last month or two, huge spike, another wave. And what people found out was that many of the people, at least 30%, maybe up to more than half, are people who had had COVID for a second time. And so you'd say, what is happening? Well, it was the Brazil variant, if you will, coming in now. And obviously, the Brazil variant was able to infect people despite having antibody and immunity to the original, if you will, COVID strain. So that gives us some insight as to what the Brazil strain may be. The other way we could look at it is some studies that come out of looking at Johnson & Johnson and Novavax, who've done studies around the world. And for example, the Johnson & Johnson vaccine, in general, if you look at wherever they studied it, the efficacy was about 72%. But in South Africa, it was 57%. So the South African strain obviously was something that was going to challenge, if you will, the current Johnson & Johnson vaccine. Similarly, when you look at Johnson & Johnson, if the South America, primarily if we're talking about the Brazilian, and again, it was about 65, a little better than South Africa, but still not the kind of rate that you would like to see. So the South African strain and the Brazilian strain are something to be considered. And even if you look, as I mentioned, Johnson & Johnson, about 57% against the South African strain efficacy. Novavax, 50% efficacy with the South African strain. Now, I don't think in general that we're going to have a problem with the UK variant that is basically taking over the United States. So we had the original, if you will, ancestral strain from Wuhan. Very quickly by spring last year, we had that taken over with the 614G, the single change in one amino acid that caused change, much more communicable. And now the, if you will, variant taking over massively is going to be the UK variant. No question, within weeks, it will be everywhere. And as we've heard earlier, we now know that we have in this country other strains. We have the South African strain and we have the Brazil strain. They're the ones to look at. They're the ones to be concerned about. And the future, if you will, whether we vaccinate a whole bunch of people or we're not doing so well yet, or we get more people infected, the future, whether we'll have an uptick or not, or have control of this, will depend on the transmission of those two strains, one from Brazil and one from South Africa.
Thank you so much. That was very thorough on the efficacy of the variant of the strain. Can someone who has been vaccinated still become infected and asymptomatically spread the virus to someone else?
It looks like that's probably so. What we don't know completely yet, when you give a vaccine, there's sort of a couple of outcomes you can have. One is, well, you don't change the rates, but you knock all the severe cases down, and so you're only talking about mild. That kind of vaccine won't stop transmission, but at least more people will be less ill. The other kind of vaccine will knock the whole rate down, probably because it interfered with carriage and therefore with transmission. We'd like to have both, where you actually have a safe vaccine, knock the rates down, knock the transmission down. There's some sort of soft reports out there that maybe the current vaccines have stopped vaccine carriage in about half the people. Well, that would be an enormous finding if really proven in more rigorous data ahead of time. So it looks as though you can probably carry the virus in some patients who have been vaccinated. We just don't know how big that's going to be and what the impact of that would be. But it means, for one thing, even after vaccination, and while we're having this wild transmission still going on, wear the mask, do the distancing, do the hand washing, stay out of crowds.
Thank you. Dr. Oliver, can you share with us the VDH plans for vaccinating the underserved communities and vulnerable populations?
That's a really, really important question. We are trying to make a balance between getting as many people vaccinated as possible while doing that in the most equitable way possible. And the way we're doing that is we have sites that have large throughput through those points of dispensing, and that way we get large numbers of people vaccinated. If you look at those sites, they do not have enough people coming through them who are from the African American, Latinx, and other communities of color, or in rural areas, it's often difficult to have very large throughput clinics as well. So there's not as much penetration in those communities. So understanding that, we've actually taken a look across the Commonwealth at communities of color, communities with a higher proportion of people who are 65 or older, who are at much higher risk of serious or disease or death from COVID-19, as well as looking at indices like income in those communities. And we've mapped out right down, we can do it right down to the census tract level, but we've mapped out communities across the Commonwealth that we think are particularly vulnerable. And we know this not just from that sort of analysis of the communities through our geographic information systems kinds of technology. We also know that from looking at the impact of COVID-19 on those communities. If you were to map case incidents in the same way, they would overlay those communities quite nicely. Knowing those where those communities are is important, because now we can plan targeted vaccination sites, mobile units, that sort of thing that can go to those communities. So you take Virginia Beach, for example. We have a large throughput vaccination site at the convention center. We vaccinate every time that's open around 1,500 to 2,000 people. We could probably quadruple that. We have the capacity to do that if we had that much vaccine. It's totally supply dependent. But 5 miles away, there are communities that have been very hard hit by COVID-19, and they're not the ones who are showing up at the convention center. So we are planning on doing special points of dispensing in those communities, and that's the way we're going to ensure that we reach those populations. So it's a both and. Do the large throughput sites and do these targeted interventions. Many communities, I live in Charlottesville, so Dr. Sifri knows that there's all kinds of things going on in Charlottesville and African American churches, other historic sites in the African American community there. Hundreds and hundreds of people are being vaccinated in that way. But it takes intentional intervention, right? If you can't just do the normal thing, you have to be mindful of the fact that those vulnerable populations need special attention, and you need to pay that attention to them.
That is so true. Dr. Sifri, how can dental health professionals best help to promote vaccine uptake and allay vaccine anxiety? And the second part of that question is, what do you say to someone who says, I'm worried about the safety of the vaccine. I don't want to put something in my body that I just don't know exactly what it will do to me?
This dovetails so much with just what Dr. Oliver was just speaking about. So, I mean, I think the first thing that you're doing right now is just learning more about the vaccine, getting the facts straight so you can be able to talk intelligently with some authority to your patients who are expressing those levels of hesitancy. I think that's critical and important. The second part that I'll always emphasize is that as a provider, having a personal relationship with your patient, I can't emphasize enough how important that is to be able to have that conversation with your patients. I think we're going to talk, and we will talk about some of the efforts about education for our community that are extensive and that really need to reach all levels of our populations, as Norm was just saying. But one thing that I think is really important that we can't shortchange is the personal relationships that we have with providers, that they're more likely to be listening to you than they'd ever be in many instances to listen to me, for example. So I think just opening that conversation is important. And as part of that, my general approach, the one that I recommend, is to start with listening, to try to understand the why people are hesitant. You gave one example there, is that I'm concerned about something being in my body. And I think that's a natural thing. There's a lot of people that are not entirely thrilled with something to be injected in them that is new and that was not in existence several months ago. That's not a silly reaction, but rather it is one that you need to understand, I think, also to validate, but then also to have that conversation. Hopefully it's a conversation that you can have if needed a couple times to understand that hesitancy. I don't like that word very much, but that hesitancy, and to understand the why. There may be other reasons as well. There may, we know people that don't believe COVID is a big problem. Why am I going to be vaccinated? I've had COVID in the past. It wasn't that bad. Why do I need to do it again? And then you can have those conversations to say, well, it is a bad disease. It is potential that if we're vaccinating, that has the potential to reduce the carrier state, that you're not transmitting it to your family or to your community or to your coworkers. You can start to explore the reasons why and maybe help address those questions. So I think that's the what I try to encourage, is to have an open conversation, and it's probably a conversation that sometimes needs to be had a couple times.
Thank you so much. I will do my best to have that conversation with my patients. I'm still waiting to get vaccinated, though. I'm still on the list. Help me move up. Dr. Wenzel, what vaccines are in the pipeline for approval?
Yeah,
and that's the final question.
Sure. There are a number, of course, but I'll just mention three because I think they'll be in front of us pretty soon at the FDA: AstraZeneca, Johnson & Johnson, Novavax. And AstraZeneca and Johnson & Johnson are viral vector vaccines. So in an adenovirus that is programmed not to replicate, to make more of itself, or to be a rogue virus and cause some problems, it can't. there's an instruction in the gene that codes for the spike protein. The Novavax actually injects the spike protein itself in encasement. I've mentioned that that in terms of Johnson & Johnson and Novavax, the new strains in South Africa and Brazil may be a little bit of a challenge. But in all of the Johnson & Johnson, it looks like in terms of severe disease, it's 85 to 90% protective. So that gives us some really encouragement that even if we don't have perfection going on in a very dynamic environment where there's a foot race between the vaccine and the variants, that we're probably going to be able to keep people from severe disease. The other thing I would say about these three, they're stable in the refrigerator for months. And that's a huge difference. So whether we're talking globally, climates where it's warm, or in the United States, rural communities, communities that are far from a big city, these are going to be the vaccines that are going to be very useful adjuncts to our armamentarium.
Thank you so much. I'll look out for them as well as looking at stock in the same same area. But I'm going to give the floor to Dr. Wenzel, who's going to do the Q&A. And I had a great discussion with you guys tonight. And thank you for being wonderful panelists. And Dr. Wendy Klein, you can take over for Q&A.
Okay. Hi, everybody. We have very little time. I want to address the question that was just posted. This is going to be speed dating for Q&A for COVID questions. If a healthcare wanted to host vaccinations, are there liability issues? This has been addressed. Dr. Oliver, are you there? I know this has been addressed and liability has been waived. Has it not?
Yes, it has been addressed in the executive order from the governor. So providers are protected.
Any other questions? If you have questions, please write them quickly. I would like to take.
Wendy, I'll add one very small part to that. I think if you do decide to vaccinate in your office, that's very difficult to do right now, as Dr. Oliver talked about earlier, because of vaccine supply. But make sure to follow the CDC guidance in terms of not only the cold storage and things that you'll need to do to store vaccine, but also the response seal. Things that I think are probably most dentist offices will already have, like EpiPens and things like that. So there's specific guidance on the what ifs if you were to start to vaccinate in your office.
And in addition, the VDH is creating guidelines to make sure that everybody who does offer the vaccine is appropriately trained. Not only is vaccine storage and handling going to be monitored, but also there will be minimal training requirements so that we know that everybody is following CDC guidance. A question that I was asked by a couple of people in the dental community is where they can get information for their patients. And I just posted a link it's on the VDH website. It is fact sheets for patients, and it is in several languages, English, Spanish, and other languages. The VDH website for healthcare providers has a lot of resources. They have really upgraded the site. So check out vdh.virginia.gov COVID-19 vaccines, and you will find a host of CDC recommendations, VDH recommendations, patient fact sheets. Can providers who are vaccinators already have an expectation of what our supply will be in the next few weeks? I'm going to jump right in here. Egg for everybody's patients. Dr. Oliver, of course, would be the go-to here, but we are all waiting across the Commonwealth and across the country. And the hardest thing is trying to get everybody to be patient, since the demand outweighs the supply right now. Anything to add?
Yeah, that's completely the truth, right? We could be doing 4 or 5 times as many people every day that we're doing now if we just had the supply, and we'd be giving it to community-based providers and all the community pharmacies. All the free clinics, the community health centers. We'd want everyone out there vaccinating if we had the
Yes.
supply. So but I will say though, Wendy, that with the limited supply that we do have, we have asked what used to be called Operation Warp Speed, and General Perna, who heads up the logistics there, we've asked them to tell us in advance, more than just a week in advance, how many doses we're going to get, because even with the scarce supply, we want to be able to plan out our clinics, right? And that's hard to do if you don't find out what you're going to get next week until,
I don't think that
Thursday.
I don't think the world of healthcare providers understands that we are at the mercy of this supply line where, as you just said, vaccine arrives without much prior notice. So it's very difficult to plan.
Yeah,
And
we find out on Thursday. It comes maybe Monday, maybe Tuesday, maybe Wednesday. You don't know exactly. This past week with the storms, we have vaccine that was shipped to us that's still in hubs that never made it to the clinics.
we are unfortunately out of time. I would like to take a minute to thank all of you who attended tonight. And I would especially like to thank our panelists who took time out of their schedules, Dr. Oliver, Dr. Wenzel, Dr. Sifri, Dr. Benson. Thank you for leading the way here, and thank you to the dental community. We would like your feedback on this panel. We need to know if we should continue to do these. There is a link in front of you that is posted, and I think we'll also, if we can, put the link in the chat. Oh, there it is, right there. There's the link. So we love your feedback. Again, my sincere thanks to everybody for participating, and everybody stay safe, wash your hands, cover your face, and thank you again.
Thank you all.
Thanks.
Thank you.
And thanks to Donald Moore for our who's our person who helps make this happen.